So we'll talk about malaria today. It's a very common disease, as you all know, and but what we don't know is how deadly and how much of mortality and morbidity it can cause. We've seen how COVID has been so talked about, and everyone is so afraid of it because of its infectious rate and its mortality rate. But when we look at malaria in the statistics, we see how malaria is even deadlier in some ways than COVID. So as usual, these are the objectives. I will define what malaria is. We'll talk about its distribution among the population. We'll talk about some of the causes, what causes malaria, life cycle of Plasmodium. Plasmodium is a parasite that causes malaria. We'll talk about some of the signs and symptoms of malaria, pathophysiology, how the what mechanisms are there behind the signs and symptoms of malaria, some of the complications that make it a deadly disease, and a brief look at the treatment of malaria. So, when we talk about definition, this was a kind of a medieval definition of malaria. The name came from mal air, means bad air. People didn't know what that was spread by mosquitoes. They just know that there was this marshland, this swampy area. If you pass by there and spend some time there, you'll have the symptoms of malaria, the fever, the chills, the rigors. So they used to associate those swampy areas with malaria, with the disease. So they thought it was something wrong with the air. So hence the name malaria. But now what we know is malaria is a parasitic infection. Infection, my bad, not infection. It's a parasitic infection transmitted by the female Anopheles mosquito that primarily affects red blood cells. Why is it only the female? Because it's the female mosquitoes that take blood meal from humans, not the males. So epidemiology, as I alluded to earlier, 300 to 500 million people are affected with malaria every year. And of those, there are 2 to 3 million deaths every year. And mostly, these are children under 5. So the cause of malaria, as I said, it's a parasite. It's caused by a parasite called Plasmodium. Now, there are different types of Plasmodium. There's Plasmodium falciparum, ovale, vivax, and malariae. Falciparum is the most common, and it's the one that causes the most severe form of malaria. Ovale and vivax have something unique about them, that they can cause this thing called latent malaria, where you're infected but you don't produce the signs and symptoms for a while. And when we look at the life cycle, I'll explain how the latency comes about. So this is the life cycle of Plasmodium. So we'll start with number 1. Just try to stay with me. I'll make it as simple as possible. So the mosquito takes an infected mosquito takes a blood meal from the human. So he injects sporozoites into the bloodstream. Sporozoites are a form of the parasite Plasmodium, which is infective. So there's sporozoites, there's trophozoites, and there's merozoites. We'll come across each of them. So the sporozoites is the infective stage of the Plasmodium. So when the mosquito takes a blood meal, the sporozoites are injected into the bloodstream and then they go into the liver. In the liver, these sporozoites start to multiply. They multiply and the liver becomes this one big fat cell because of the multiplication of the sporozoites, and that big fat cell is called a schizont. And when the schizont ruptures, it releases now the daughter parasites, which are called merozoites. The merozoites then go into the red blood cells, the erythrocytic stage, and they infect the red blood cells. Again, inside the red blood cells, now they mature into trophozoites. These are the ring stage parasites. This is now the active feeding stage of the parasite. This is what they actually, at this stage, they eat. So this is the feeding stage of the parasite. So even the trophozoites start multiplying within the red blood cells. The red blood cell becomes this fat cell called a schizont. Then it ruptures, releasing the merozoites again into the blood, and the merozoites now infect other red blood cells. So the whole erythrocytic stage will continue. Now the thing about the erythrocytic stage is it's at this stage where the signs and symptoms of malaria starts to present. So it's a very important stage in the pathophysiology of malaria. So all this that I mentioned is the asexual stage. You'll notice I never mentioned any male or female gametes or any male or female cells, because all this is asexual reproduction. However, in the erythrocytic stage, some of the red blood cells, some of the plasmodium, instead of going into the normal, the trophozoites and then merozoites, some of the plasmodium enters the sexual stage, where it forms the male and female gametocytes, which is the micro and macro gametocytes. The micro is the male, the macro is the female. So these red blood cells with the micro and macro gametocytes, an uninfected mosquito will come and take a blood meal. These red blood cells will be taken up by the mosquito, and inside the mosquito, the male and female gametocytes will be digested into male and female gametes. Now these gametes will fuse, fertilization will take place, forming a zygote. This is again inside the mosquito. The zygote will now form into an ookinete. The ookinete will now move into the mosquito midgut wall, forming an oocyte. And from the oocyte, the mosquito will release the sporozoites now. The sporozoites will go into the salivary glands of the mosquito, ready to infect another human. Remember, I said the sporozoites were the infective stage of the parasite. Now, let me go back to ovale and vivax, the ones I mentioned earlier. So what happened? What causes the latent infection? It's the ovale and vivax. When they enter the liver stage, they have the ability to stop their cycle there for a while. Instead of rupturing, instead of the liver cell forming a schizont and rupturing and infecting the red blood cells, they'll just remain within the liver for a while, and when it's time, they'll then go into the erythrocytic stage. So because they can lie dormant and sleepy in the liver for a while, they are called hypnozoites. So we'll see how we deal with such parasites. So these are the signs and symptoms. Uh, I'm sure we're all aware of some of them. It's fevers, rigors, chills, headaches, and low blood pressure. I'll explain how the low blood pressure comes about. So pathophysiology of malaria. So the function of the spleen. We all know that the function of the spleen is to break down any damaged or red blood cells which are not normal. So when the red blood cells are infected with the plasmodium parasite, the spleen will detect this and they'll start destroying these red blood cells. So the first step to malaria is hemolytic anemia, because there will be extravascular hemolysis, because the splenic macrophages will be taking down those infected red blood cells. So when your red blood cells start getting destroyed, it causes reduced hemoglobin in the body, so anemia. And because it's a breakdown of red blood cells, it will cause hemolysis. So there'll be an element of jaundice to anyone with malaria. Now, the main culprit of malaria is our own cytokines. The body's response to a foreigner is to produce cytokines, and the cytokines have tremendous effects on the body. Most of it is harmful to the body itself. So what happens is, when these infected red blood cells are exposed to splenic macrophages, and the macrophages destroy the red blood cells, or even just by being exposed to the parasitic red blood cells, it will trigger an immune response where the macrophages will start producing cytokines. The main cytokines that are involved in malaria are interleukin 1, tumor necrosis factor alpha, and interferon gamma. Now, these cytokines have four main effects. One of them is the fever, chills, and rigor, the ones that are the bread and butter of malaria. And then we also have bone marrow suppression. Now, when someone asks what's the causes of anemia in a patient with malaria, one of them obviously is the mechanical destruction of the red blood cells by the splenic macrophages. The other one is the cytokines that are produced by the splenic macrophages, which suppress hematopoiesis in the bone marrow, causing anemia. There's increased vascular permeability. As you know, the capillary vessels are lined with cells that are almost, they are watertight in many ways. They are closely tight to each other, but in response to such cytokines, the cells open up and water starts to leak out. So this is called increased vascular permeability, causing leakage of fluid out of the vessels, and hence this can cause the low blood pressure that we saw in the signs and symptoms. And then increased vascular adhesion. This effect of cytokines is the one that causes lots of problems. Interferon gamma especially is the one that's the cause of this. The capillary vessels to start to exhibit adhesion molecules in their walls. So when the red blood cells flow through the vessel wall, because of the adhesion molecules, the red blood cells start to stick to the capillary wall. Now, when many red blood cells stick to the capillary wall, they form like a cluster, a clump. This it's called a rosette. When you see it in a microscope, it's called a rosette formation. So there is, imagine group of red blood cells sticking at various parts of a capillary wall. Now, what the body does is whenever there is something abnormal, especially in the vessels, even if it's its own red blood cells, but now they've clumped together, so it's abnormal, the body will attack it. So, how will it attack it? Using neutrophils, macrophages, complement all those the immune arm of the body. So now, the neutrophils and macrophages are attacking the wall which has the clustered red blood cells. So, because of this attack, you'll have inflammation. So the vessel wall will start to swell. So as it swells, then the lumen will narrow and causing blockage. So the end organ which the vessel was supplying will get less oxygen and less nutrients. And this is the most problematic thing of malaria. It's blockage of vessel wall and the end organ damage because of the rosette formation. So the complications are because of that inflammation of the vessel wall and blockage of the lumen of the vessel. So cerebral malaria is a very severe complication of malaria. This is when the inflammation of the vessels occur in the brain. So the parts of the brain gets less oxygen and less nutrients. So presenting with cerebral malaria. So its presentation is similar to encephalopathy. So coma is one of the main presentations of cerebral malaria. There is also seizures, but mostly it's reduced consciousness. So coma-like symptoms, and also it could present with uh, cerebral vascular accident-like symptoms. You can have paralysis, you can have stiffness, but mostly it's seizures and coma. Again, if the vessel walls that are affected are in the lungs, it will cause acute respiratory distress syndrome, usually pulmonary edema in the lungs. If it's in the kidney, excuse me, if the glomeruli are affected, it will cause less blood reaching the kidneys, causing acute renal failure. Again, if you are pregnant and placenta is the main conduit of communication and passage of nutrients and oxygen between the mother and the fetus, anything causing blockage of the placental vessels will affect the fetus badly. It could lead to fetal death, it could lead to fetal growth retardation. So it's called placental malaria. Now, black water fever, it's the name is derived from when a person starts to micturate darkish urine, almost black. Now, the cause of the blackness is it's hemoglobinuria. It's hemoglobin in the urine because remember, the splenic macrophages are destroying the red blood cells. So as they destroy the hemoglobin now, first of all, it comes into the blood and then some of it starts to be removed through the urine. So when you have a lot of hemoglobin in the urine, the color of the urine becomes dark. Metabolic acidosis, because your kidneys are not working well, and one of the functions of the kidney is to pump out hydrogen ions in the urine. So when the kidney is not pumping out hydrogen ions, the hydrogen ions remain in the body. So there's an acidotic picture. Severe anemia again, we saw the two causes of anemia. One is the mechanical destruction of the red blood cells, and the other one is the cytokine-induced bone marrow suppression. Bleeding disorder, this is because of the spleen. Remember, the work of the spleen is to destroy defective red blood cells. So because there are so many red blood cells which are defective because of the parasite, the spleen is overworking. So the spleen will also try to increase its workload and increase its functionality, so it'll become big. So splenomegaly is one of the presenting symptoms. So the spleen will become big. As the spleen becomes big, all its functions will now get exaggerated. So apart from destroying the damaged or infected red blood cells, it will also destroy some of the normal cells. So some of the normal RBCs will be destroyed, and even the normal platelets. So if the normal platelets are sequestered and destroyed, we'll have thrombocytopenia, and thrombocytopenia will lead to a bleeding disorder. Now a brief look at the treatment of malaria. So these are the classes of drugs that are used to treat malaria. There's quinolones, atovaquone, antibiotics, primaquine, and artemisinin-based therapy. Artemisinin-based therapy is the one that's most effective, and it's used a lot in the world and in Kenya especially. So some of the quinolones are chloroquine, quinine, and lumefantrine. And the antibiotics that we use are sulfur-based, pyrimethamine, sulfamethoxazole. We also have diaminopyridines. Of note, uh, I'll talk about the mechanism of action of this each class of these drugs in another video. But of note, chloroquine, Plasmodium falciparum especially, has developed resistance to chloroquine. So it's not used that much. Chloroquine, we tend to go to artemisinin-based therapy, and sometimes if we don't have those, we can go for quinine, although quinine has a few side effects. So primaquine, the thing about primaquine, it's the one that causes radical cure, because remember we talked about Plasmodium ovale and vivax, and they're hypnozoites, the one that can stay in the liver without causing any symptoms. So we may destroy the parasites in the red blood cells, and we think we've cured, but then there are those hypnozoites in the liver cells that are just waiting to jump into the red blood cells whenever the coast is clear. So when we give primaquine has the ability to destroy the parasite while it's in the resting stage in the liver. So it's the one that causes radical cure. A brief look at the Kenyan guidelines. So when we have severe malaria, again, severe malaria is usually caused by Plasmodium falciparum. So this is the regimen we use. We use IV artesunate. It's IV. So it's usually given at 0, 12, 24 hours. This is after you come to the hospital. And then it's not PO, sorry, it should be OD, once a day. And then you give it once a day, every day, until the patient can tolerate an oral dose. The oral dose is artemether lumefantrine, which is the go-to for uncomplicated malaria.